Thank you very much, Ibu Dia, for your comprehensive review for day 1. And then for day 2. And then the material 1, we will have move on to the next activity. We will have the material about the implementation of MCH Handbook in the World on Continuum of Care from Ms. Keiko Osaki, Senior Advisor of Health JICA Headquarters. This session will be moderated by Dr. Amelia Alfrida from WHO Indonesia. The floor is yours, Dr. Amelia.
Yes, thank you so much. Hello and good afternoon, everyone. So for the second day, we will start the meeting with the presentation regarding the implementation of MCH Handbook in the world, and also continuum of care for maternal, newborn, and child health. So for this session, the presentation will be given by Ms. Keiko Osaki. She is the Senior Advisor on Health in Japan International Cooperation Agency. She has extensive experiences for home-based report and also MCH Handbook in Asia and Africa in more than 10 countries. And she also have quite extensive writing and publication on this area. So, Ms. Keiko, time is yours.
Thank you, Maria, for your kind introduction. I hope you can see the slides.
Yes, we can.
Yes, I can see.
Yeah,
thank you.
Thank you. Today, I'd like to talk about the implementation of MCH Handbook in the world and continuum care. I will talk 2 points: the WHO guidelines on home-based recourse and the lessons learned from countries with MCH Handbooks for continuum care. The first question to you is, do you know about the WHO guidelines on home-based recourse for maternal, newborn, and child health? Could you find out information you need in the guidelines? If no, don't worry, but let's listen to my talk. The guideline was issued in year 2018, and it's launched in 2019 at the 72nd World Health Assembly official side event, which was hosted by Indonesia, Afghanistan, Kenya, Laos, Philippines, Myanmar, India, and JICA as Japan, and UNICEF and other major partners attended. Since its inception, such kind of the world voices, world agenda. Home-based record is individual's health history, covering essential service uptakes. It's kept at home and mobile. It's nearly used by every country, but very different to use across countries and within countries. It's expected to be integrated into a health information system to complement records held at health facilities. It's a tool to ensure right to access to information. Therefore, it's a people-centered tool, and MCH Handbook is definitely a kind of home-based record. You may be aware that various types of home-based records exist in the world. For example, for mother, maternal card, for pre-post delivery and between pregnancies. For child, vaccination card and a growth chart, separately, or sometimes those are combined into one booklet. MCH Handbook, as the name tells that, it covers all MCH stages as an integrated format. Therefore, its beneficiaries are pregnant women, mothers, children, and caregivers. Before these guidelines, only some guides were available separately for immunization card or maternal record. Considering the potential values of home-based records as an essential tool for continuum of care, the evidences were collected and reviewed to develop guidelines. Based on available evidences for various types of home-based records, WHO recommends the use of home-based records to improve care-seeking behavior male involvement and support in the household, maternal and child home care practices, infant and child feeding, and the communication between health providers and women caregivers. No undesirable effects were reported yet, but comparing to such wide range of outcomes of our interests, unfortunately, quantity of evidences was still limited. Therefore, this recommendation was based on low certainty evidences. If you'd like to find out more details, you may find some relevant pages. Okay, so on outcome MCH or on outcomes on health systems. So for example, some small desirable effects on child health was reported positively on page 12 in terms of sick care, exclusive breastfeeding, complementary feeding, continued breastfeeding, vitamin A home care. Regarding continuity of care across MCH, pregnancy period, delivery, and child feeding. So for the care aspect, you may find some desirable effects on explanation and identification of complications by health workers, and the satisfaction communication, sense of controls by clients, a kind of the experience, the care quality is reported around page on 14th. Those are through the three sets of the comparisons between any home-based record use versus no home-based record. Any home-based records use versus low use, or use of different types of home-based records. So the three sets of comparisons by two outcome groups, making the 6 key questions as its construction. The first recommendation was regarding the values of home-based records. The second recommendation is research on the research gaps and implementation challenges. To determine which type is superior to other types, we need to wait for further researches. Also, beyond types and the contents of home-based records, importance of implementation of home-based records were emphasized. Implementation consideration was called by the guideline development groups, which is consisted by experts as well as the representatives from the countries like Uganda, Kenya, and Indonesia. The course implementation matters. It's not only for design and context, but also for training, sustainability, planning, health education, and the potentials for harm need to be continuously discussed and addressed. So, this is the first comprehensive guidelines by WHO on home-based records to support continuum of care for maternal, newborn, and child health. So it will help you to identify reported values in various aspects, to acknowledge implementation challenges, and to know about research gaps. So let's move to the lessons from the countries. We know its potential to be a good tool for the continuum care, but how? To cover these points, let me briefly introduce MCH Handbook in Japan, as it's been used for more than 7 decades. It's rooted from the Maternal Handbook in 1942. It's linked to the pregnancy registration and the monitoring for the food ration at the time. It's expanded to cover child period since 1947 under the Child Welfare Act. At the time, MMR was around 160, IMR was around 60. Since 1965, it's more clearly located in the health system under the Maternal and the Child Health Act. Since then, the self-care monitoring components is included and used until now. Like your countries, across essential MCH services in Japan, MCH Handbook works as a platform to cover time across life courses since pregnancy to child, and at the place where the setting care provided, and also the practice, starting from home to hospital. Letting women mothers own their data throughout MCH period is rational for Japanese society, as Satogaeri Shussan, delivery at hometown, have been commonly observed. In reality, who use it? For example, during the pregnancy till the delivery, prenatal care site, midwives and doctors are recorded at clinics. Pre-mama papa has a chances to be educated through the group sessions, and usually either guided by the public health nurses or midwives. They are explained about the contents of the MCH handbook and then bring back to home. Weight chart during pregnancy is expected to plotted by pregnant women at home. At hospital, the delivery data is recorded by doctors and midwives. So it's not only used by a single professionals like midwives, but also by multiple professionals and women by themselves. According to a cross-sectional study with caregivers who attended child regular health checkups, caregivers put notes on it as designed. They brought it to service points, rarely lost it, and they were satisfied with the contents. We may say it's well used. So maybe it's located in the administrative system. In the left-hand side, in Japan, the local governments have responsibility to provide MCH services, including MCH handbook procurement under the Maternal and Child Health Act. Public center, the first level of public health facility, issues it to client and the health practitioners of the health facilities from the first level to the tertiary level, as well as both in public or in private, acknowledge it and use it. Therefore, MCH handbook works as a referral tool. In other countries, for example, on the right-hand side, the Health Ministry's ordinance may provide a basis for budgeting of MCH handbook procurement, and health workers at the first level public health facility issues and use it. But commonly, we have observed that some more efforts are needed to make every health workers in every kinds of health facilities to use it. And budgeting MCH handbook procurement does not necessarily accompany to the budgeting MCH services together. Maintenance of MCH handbook in health system is other important issue. Along with declining IMR, MCH agenda shifted in Japan. MCH handbook was adjusted to shifted needs through periodical revisions. As I told you, when the MCH handbook started, IMR was around 60. Promotion of care was an issue. When IMR was around 30, early detection and treatment of childhood diseases was an issue. So we need to maintain MCH handbook by adjusting to the changed context. So MCH handbook is needed to be put well in the health system and administrative system. Next, do you think your MCH handbook is optimally used in your country? If not, why and how to make it? Looking at the MCH handbooks in several countries, we may be able to categorize the expected functions into 3 levels. First, data recording and storing function is to make individual MCH-related data available at home and mobile. Second, behavior change and communication function is to be home-based references and a prompt for upcoming care and communication media between mothers, health workers, and caregivers. Third, referral and self-monitoring function is to support a continuum of care across facilities and self-monitoring guides at home. We may be able to draw a diagram of those functions in the relationship with respective necessary capacity levels for both users, health workers, and mothers and caregivers, and they may progressively positively increase. For level 1 function, health workers needs to conduct clinical tasks, of course, then record data on MCH handbooks. Mothers needs to take MCH handbooks to health facilities at visits and retain it at home. For level 2 function, Mothers need to be able to read and understand the contents of MCH handbooks, and health workers are capable to use MCH handbooks for health education. For the third level function, health workers need to remind their clients to take MCH handbooks to higher or lower level facilities, and recognizing MCH handbooks as their referral form. Mothers need to take MCH handbooks to health facilities at referral, of course, not only for immunization, and record MCH home care status if it's designed. Gaps between expectations and the realities may have caused underuse. To enable expected function, real levels of expected function and the levels of required capacities need to be understood. If the capacity gaps caused underutilization of MCH handbooks, this diagram may assist you in identifying and filling the discrepancy between the functions you expect and the functions that can be realized within the current capacities of users. If the MCH handbook is designed for higher level functions for users of lower capacities at this moment, you may take one from two options. One, downgrade expected functions, like from level 2 to level 1. Or second, add supplementary elements to increase the current users' capacities to the required level of users' capacities. To fill the gaps, designing records is the greater user friendliness is always a good answer you may take. Definitely, health workers will be more positive if the format is more efficiently and simple, and they transcribe the data from facility data to ONET. And the mothers and the caregivers are more attractive, more positive to not lose it and retain it, or even they will access to the services to obtain the very good contents of MCH handbook for them. Supportive interventions for increasing users' capacities is always a good answer as well. But the essential point is we need to start the service provision with the MCH handbooks be accompanied as essential. So because we always need monitoring tool of the service performances. Health workers' capacities could be increased through the orientation refresher trainings, guides and manuals, and the follow-up and supportive supervisions, as you already noted. And pre-service educations and health professional organizations may provide some more opportunities to have some influence to the health workers in both in public and or the private health facilities. Mothers and the caregivers' capacities could be increased by adding and providing supplemental education sessions by using the basic contents of MCH handbook. Lao case is very attractive, so they created the good, effective, and the practical guides for the technical persons to use the MCH handbook in the service provision, and it's accompanied by the technical trainings to increase the skills of health personnel by explaining, assessing, screening, and recording and counseling. So those are tested by the pre and the post to confirm the rational relevance of the contents of the trainings. I guess there's some more challenges remain that we admire their efforts to make it happen. The quality care, continuum care with the help of effective use of MCH handbook. Another example from Indonesia, a research conducted in Indonesia confirmed that the effective use intervention of MCH handbook can make change in continuum care uptake. But in other words, so without effective use, we cannot expect continuum care uptake is increased. So no effective use, no outcomes. Understanding the gaps between expectations and the reality is a start to plan to fill the gaps. The last question, does MCH handbook benefit every woman and every child in your country? If not, how to do it? Understanding the current maturity of implementation is a start to plan and increase maturity of implementation in your country. If you or the country have a plan to have a new version of MCH handbook, or there's some combination of the existing recourse into the MCH handbook, you may have identified some issues to be addressed through it. So pilot test and the pilot tested version will become the national version. So that's kind of activities you may think. And if you are the country with a national version at your hand, but still some challenges in the implementation in the nationwide, so you have some activities around this. And if you are the country with quite a good coverage, but still the challenge and the quality use, as well as some constant procurement and periodical revision as in the health systems, maybe you can identify some more activities around here. This map recalls us, this is our homework, because only little number of the countries tells that their child at the age of the 1 year old have the owner of their own recourse, the recourse on immunization. So we can do many things, and the guidelines help us to do it for the effective use of MCH handbook for continuum care, and the other countries' good practices will further your action plans. So let's continue to discuss and learn together. Thank you for your attention.
Yes, thank you so much, Keiko-san. You really made it in less than 20 minutes, a lot of information, quite concise. And I think it will be very interesting and very important for all our distinguished participants, right? Because you also mentioning 4 questions that can be reflected when we are going through the whole meeting and when we're going to make a plan of action. In the chat box, I don't see any question, but because due to the time constraint and we have quite a compact agenda for the next session, probably we can close, but I think you already put your email address in the last
Yes.
slide. So if participants have a question, I think it is allowed for them, right? To you for any
I'd love to get
any
questions.
support and any, right? Okay. Thank you so much, Kiko-san, for your time and presentation. And for the next session, I over it back to the committee. Thank you so much.
Thank you very much, Dr. Amelia, for moderating the panel, and also Ms. Keiko-san for your presentation. Thank you very much. Ladies and gentlemen, we will now move on to the next session. So in this session, we will have a country presentation from Laos, Madagascar, and Papua New Guinea. So please, the country that I mentioned, please be prepared. And this session will be moderated by Dr. Sri Wahyuni, Deputy Director for Bilateral Health Cooperation. So without further ado, Dr. Sri Wahyuni, the time is yours.
Okay, thank you so much. Thank you, Ms. Yoshita. It's very pleasure to be here this afternoon. Distinguished colleagues and participants, I'm Dr. Sri Wahyuni. I'm Deputy Director for International Cooperation in Bureau of International Cooperation, Ministry of Health, Republic of Indonesia. Allow me to be the moderator of this afternoon session. So in this session, we will have 3 presentations from 3 countries, which is Laos, PDR, Madagascar, and Papua New Guinea. Each of country will present for 10 minutes. And in the end of the session, we will have 15 minutes discussion. So for the first presentation, we'll have Laos, PDR. If I may share a brief information about Laos PDR has progressed on the action plan for KSP last year, such as conducting master trainers at central level to supervise provincial staff, and has integrated the MCH handbook into the curriculum of medical doctors, physician assistants, midwife, and nurses, and also suggests both public and private sectors to use MCH Handbook. Laopedia also have recommendation for essential services in the pandemic era. I would like to kindly invite Dr. Alongkon from Laopedia to present the country report. You have the floor, Dr. Alongkon.
Okay, please, the organizer will share my slide. Hello?
Hello.
Okay, next, please. Okay, good afternoon. Okay, can I present now?
Yes, please, doctor.
Yeah. First of all, I would like to say thanks to Indonesia and also JICA to support and give us an opportunity to present and sharing the information regarding the MCH handbook in my country. I starting with the country profile. Laos, very small landlocked country located in Southeast Asia. We are in the mainland with the population of 7.6 million. The surface area of our country is 236 square kilometer. We also have administrative province for 18 province. The maternal mortality rate is about 167 per 100,000 live birth. Total fertility rate is 2.65, and contraceptive prevalence rate is 55. And we also have the undefined mortality rate about 46 per 1,000 live birth. And we also have some stunting, about 32%, and the underweight children under 5 years and 20%. Next, please. Because I also to talk briefly about the reproductive health, maternal and neonatal and child health national strategy. We divide into the 6 strategic objectives. The objective 1 is reproductive health, and the objective 2 is maternal health. Why I get the highlight in the red letter that the maternal health in my country, including antenatal care, emergency obstetric care, safe motherhood program, maternal death surveillance, and safe abortion. This is like the content which is included into the strategic objective 2. And objective number 3, we also have the early essential newborn care. And for the objective number 4, we also have the issue regarding the healthy child. And the objective number 5 is the 6 children. And objective number 6 is the community and village health volunteer. This is like the 6th national strategy regarding to the reproductive, maternal and neonatal and child health national strategy. Like Laopedia, we edit the last edition on 2020 because we changed the cover, and we also changed in the content inside the handbook. And we also conduct the cascade training throughout the country. And we also develop the standard of antenatal care and so apply to all facility. Because for the facility, we divide it into 4 levels. The first one, we have the tertiary care in the central hospital, and the secondary care for the provincial hospital, and the primary care is a district hospital. And we also have the sub-primary care, like in the health center. Because the MCH indicator approved by the Lao National Assembly 2020 is ANC and SBA should be 100% by 2025. Next, please. Yeah, because this is the progress of the last action plan, because we have another group of the participants attend to the KPS 2020, and then they also set up the action plan, and we also follow the action plan like this. The first one, we conduct the master trainer at the central level and then supervise into provincial staff and the peripheral staff. We also integrated the lesson of the MCH handbook to the pre-service training like a medical doctor curriculum, PA or physician assistant curriculum, midwife and nursing curriculum. We also conduct the high-risk screening. Like the high-risk screening, we just based on the respectful care, individual counseling, the preparedness plan, and we also apply this because we want to increase the ANC at the institutional delivery. We also have a plan, some monitoring and evaluation and supervision to conduct the utilization of the MCH handbook. We also have the project like empowering the community, and we also try to encourage and sensitize the school teacher, discuss about MCH handbook with them, because why we use a school teacher? Because of the school teacher, the parent, they bring the children to school, because we try to have some regulation that if the children don't have the MCH handbook, they cannot come to the grade 1 of the primary school. And also we plan to suggest both public and private sector to use the MCH handbook. It's the same handbook and very unique for the whole country. Next, please.
Dr. Aonkon, if I may remind the time, you have 4 more minutes. Thank you.
Yeah. Next, please. We also have we suggest the mass organization like the women union in the village to support it. And also we integrate the outreach activity. And we also train the village health worker to work in the community in terms of the health promotion. Next, please. Yeah, this is the recommendation during the COVID pandemic, because we use this to integrate to the routine, the antenatal care and the delivery service as well. Yeah, this is the recommendation. This will be also focused on the recommendation to the pregnant women with the COVID. Like they can come to the ANC routinely. If they cannot come, maybe we use the telehealth. Like we contact with them with the telephone or using the WhatsApp. Next, please. And for the vaccination in Laos, we just recommend the pregnant women who have over 12 weeks of pregnancy can receive the vaccination. Next, please. Yeah, this is like during delivery. Okay, we also suggest them they can the cesarean indication should be based on the obstetrical indication, no more for the elective cesarean section. We try to avoid the unnecessary cesarean section, and we just focus routinely the skin to skin, and the mother and the baby should not be separate. They should live together in the same room. Next, please. Yeah, this one for the breastfeeding. For the breastfeeding, we also suggest the women with the COVID infection having the exclusive breastfeeding routinely as usual. Next, please. For the monitoring and evaluation, we will also have the clinical audit and the chart review from ANC record, and the near miss audit for severe case of obstetric and will conduct including the history of ANC. We also conduct the data verification for ANC, and the head of ANC and MCH supervise their staff in terms of plotting and marking the MCH handbook. This is the type of evaluation that we conducted, but it still have the big challenge as well. Next, please. We can also want to learn from another country, like the training and like the supervision and how to use the MCH handbook, and what about the empower the community, how to get better understanding, how to change their behavior, because the Lao women, they also always forget to bring the MCH handbook to the ANC, and also the care provider they are also like they don't interested about the review every time when the pregnant women come with the NC. they did not review the MCH handbook every time. This is our big challenge. Then we need to learn from another country to improve our situation. Thank you very much.
Thank you very much, Dr. Alonkon. It's very timely. Very nice time arrangement. So we want to continue with Madagascar for the second presentation. This is the first time for Madagascar to join KSP. Madagascar has two different handbooks, one for mother and the other one for child. In the era of pandemic, Madagascar has financial and technical support, has mobile clinic for MCH, free transport for antenatal care or delivery services, and vaccination for the children, and also has online training and webinar. Now, I would like to kindly invite Mr. Jules from Madagascar to present the country report. Mr. Jules, you have the floor.
Thank you for giving me the floor. Good afternoon, ladies and gentlemen. My name is Jules, Head of Research and Development at National Nutrition Officer. It's a great pleasure for me to share with you our country report. As you know, Madagascar is an island nation in the Indian Ocean of the southeast coast of Africa. I now see this presentation. Are you hear me? Are you hear me?
Yes, we can hear you, Mr. Jules. You may continue, please.
What? Are you hear me?
Yes, Mr. Jules, we can hear you very clear.
I'm really sorry for the connection. I will continue about geographic condition in Madagascar. So Madagascar should be the top of the destination if you talk about its natural beauty and endemic wildlife. Madagascar has got two seasons, a warm and wet season from November to April, and a colder and dry season from May to October. So 587,041 square kilometers of superficie in Madagascar and 28,048,127 Malagasy people. We are 23 regions and 119 districts of health and 678 communities. Next, please. So, how about maternal and child status? As you can see on the screen, in the life, there are data according to the mix in 2018. So about antenatal care for 4 times, we have 30.6%, and antenatal care 8 times, 1.7%. About scouts birth attendance, we have 47.9%, and the delivery and health facility 38.7%. About contraceptive prevalence, we are 14%, and totality fertility rate 4.3. About the child status, we are 18.7% child with vitamin A, and 19.6% of children aged 12 and 59 months were deworming, and exclusive breastfeeding there are 51%, early and exclusive breastfeeding 45%, and statin there are 13 to years percent of children under 5 years old, and wasting 6% of children under 5 years old. About underweight, there are 26% of children under 5 years old, and overweight 1.4% of children under 5 years, and 12.6% of infants having a low weight and birth anemia effect, 36.8% of men, and overweight 1.4% of children under 5 years. So next, please. Next, please. So about the current implementation status of MCH Handbook in national health. So let's talk about the current status. As you know, maternal and child health has been well developed in the health system in Madagascar. Two different handbooks have been made available to beneficiaries. This handbook have been updated in 2013, and in 2019, the elements that have been affected by the update concern the integration of physical, intellectual, and psychomotor development of a child, the growth curve, the situation of the infant, young children, and pregnant women as recommended by the WHO. Next slide, slide 4.
Mr. Jules, your time is 4 more minutes. Thank you.
This year is the first participation of Madagascar teams to KSP, so we have not yet information about the progress of last year's action plan. Next slide. Sharing the experience of community improvement. In most cases, the majority of the sensitization were based on the health and nutrition essential in maternal and child health manual during a pandemic. We have been able to slow the spread of disease through increasing awareness using mass media and social network. Due to the support of partners, the area most affected by pandemic have benefited from health support and sanitation with Handbook. Health workers from the public and private sector, traditional practitioner and community worker have been sensitized. Next slide. As you can see in the picture, the service offered for the patient due to the awareness with used Handbook. Next slide. Slide 7. In this slide, we will look our experience concerning capacity building of health workers during the pandemic. So there are e-learning platforms have been set up of program managers and the state level to train health workers, and the local government level on pandemic response and maintaining essential services. There is also a webinar on maternal and child health with a program manager, the partner who have recruited to work in the mobile clinic and health workers. Webinar about maternal and child health. In brief, the purpose is bridge to the gap in capacity building for health workers and improve service delivery. Slide 8, concerning the experience of conduct of monitoring, there is a periodic review We want to know if Handbook is usually used correctly by the community health workers and beneficiaries, and understand the content of Handbook, to check the availability of Handbook in the health center and nutritional set at the community level, to make sure that its child and their review has and Handbook slide 9. Finally, our expectation concern learn best practice on the use of MCH book from other countries, and fourth, the concept of this training program, learn from other countries how they perform monitoring and evaluation of the MCH book, learn how to have an easy to use health record for mother and child health, learn how to establish the implementation plan of the best practice of other countries, continuum of careful utilization of Handbook. Ladies and gentlemen, that's the end of my presentation, so thank you so much.
Thank you so much, Mr. Jose. It's very timely. Thank you for your presentations. So maybe continue to the presentation from Papua New Guinea. This is also the first time for Papua New Guinea to join KSP. The implementation of MCH Handbook in the pandemic era was challenging. For the monitoring in the pandemic era, PNG has set up National Control Center who receive health information from all health facilities. Now I would like to kindly invite Ms. Mary from Papua New Guinea to present the country report. Ms. Mary, you have the floor.
Good. Hello to everyone. Mary here from Papua New Guinea. Yeah, it's the three of us, so I'm happy to present to you the country report for my country, Papua New Guinea. Next, please. This is Papua New Guinea. It's situated on the north of Australia. Next, please. Okay, this is the country profile. Papua New Guinea is located in the southwestern Pacific Ocean and is the world's second largest island with 4 main regions and 22 provinces, 89 districts. Its mainland, it's around 600 islands, and it occupies a total land area of approximately 452,860 square kilometers. It is culturally diverse with over 600 ethnic groups and tribes and 800 plus native languages. We speak 3 main languages in Papua New Guinea, and that's English, Pidgin, and Motu. Papua New Guinea has a population of almost 9 million people. The country's population growth rate is about 2.5 to 3%. Approximately 80% of the population live in the rural areas and 20% live in the towns and cities. Papua New Guinea has a percentage of 96% of them. It's made up of a Christian nation, Christian people. Next, please. Maternal and child health status. PNG has 6 levels of health care facilities. That's level 1 to level 6. I'm working in the level 6 hospital, which is the National Referral Hospital of Papua New Guinea, and I'm a midwife here. We have 20 private health facilities in the country. We have 7 regional hospitals, 19 provincial hospitals, 89 district hospitals, 677 health centers, and 2,600 health aid posts. The country has the highest rate of maternal and newborn mortality according to WHO Western Pacific region. Maternal mortality rate is about, we've done well. We were 733 per 100,000, and we've improved to 145 per 100,000. That's the statistics from 2017. Infant mortality rate, 39 deaths per 1,000 live births. Neonatal mortality rate is around 21.9 per 1,000 live births. Child mortality, 48.8 per 1,000 live births. Contraceptive prevalence rate is around 32.4. It's lowest also in the Western Pacific. Antenatal coverage is around 67% of women attend antenatal care. 55% meets the WHO, but for more than 4 clinics, according to WHO, women must attend clinic 4 times to be called as their booked women. Vaccination children less than 2 years of old is lowest also in the Western Pacific. Delivery in health facilities around 40%. Delivery by a healthcare worker is also around 40%. Next, please. Our country profile, the current implementation status of the MCH book. In PNG, we use 2 health record books. We have a different health record book for the women, and we have a different health record book for the infant. And it's both used in all across the country in all health facilities, except the private hospitals, they use card system in their facilities. Next, please. This is our first time to attend a KSP. So next slide, please. How do your country empower the community through utilization in the pandemic era? Yes, we have a lot of challenges like all the other countries have faced. Yes, we have a lot of challenges, but we try to manage through. It was very challenging during the first and the second wave of the pandemic in terms of antenatal visits, family planning, immunization programs were affected. Essential cares that we were supposed to give to the women were also affected. But we tend to, with the help of our donor funders and our support, WHO, UNFPA, all this, we managed to put things together to cope with the pandemic. Next slide, please. Slowly getting used to the pandemic, and all programs for maternal and child health continue as usual, with challenges following. We are following the WHO guidelines in making sure that essential services are met by all women and all children, and they are not denied of the right to their care. More awareness and publications are going on through TV, radio, social media platforms were used also to advocate, and we are now getting used to it, and the continuity of essential services is still on, but still challenging with the third wave eating us right now. But thank God, God is always on our side, and we are going to manage it. Thank you. Next slide.
Ms. Mary, you have 4 more minutes for the presentation.
Yeah, in healthcare capacity building for healthcare workers, yes, we go through sessions on IPC training, psychosocial preparation during the pandemic to get the minds of staff, get used to what the new changes coming up. And then we have medical checks for staff to be medically fit to work during the pandemic, physical, social, spiritual preparation. We have more awareness on disease itself, and we have regular meetings with COVID task force and team to disseminate new information on the pandemic. Next slide. Okay. As data, yes, we are the implementation. We are everything about women, maternal and child health. Yes, we do implement all these things, and we give report back to the National Department of Health. And also the country has we have set up a national control center, which is run by the Pandemic Response Task Force, and they receive all our information in regard to in all facilities. It's all reported to the Pandemic Control Center, and the report comes back to us. Next slide, please. Okay, what we want to learn from you other countries, how to manage the pandemic in terms of MCH, the reporting and evaluation of the program, how best you are doing it, and the best method that will be used in collecting the data to improve our health indicators. Next. I think that's about from us. Thank you so much.
Thank you so much, Ms. Mary. Very timely. And thank you for the presentation. Now we come to the discussion session. I see from the chat that many questions have coming in, and then Dr. Alungpon already responds some of the questions in the chat. If I may allow to read more questions that has not been responded. One example, the question coming from Augusta from Timor-Leste, question for Madagascar. The question is, do you offer free transport for mother to attend ANC in mobile clinic or in routine health facilities? For Mr. Jules, you may want to respond to that question. Mr. Jules, are you there? We have a question for you. Can you hear us? Maybe the connection is not really good in Madagascar. Okay. Here we have Mr. Jules.
Me?
Yes, we can hear you.
Do you hear me? Please?
Yes, we can hear you. Do you notice about the question?
So about the fourth question,
Yes.
it's
do you want me to read the question for you?
So about the first question about transport for mobile to attend MCH in mobile clinic. As you know, we are free of through 20 regions are covered of this clinic mobile. And the most height of endemic area offer free.
Mr. Jules, are you with us? Hello, Mr. Jules. I think we lost Mr. Jules. So if we can jump to another question for Papua New Guinea, Ms. Mary, you have questions?
Yes.
In the chat, you may want to respond to that question, or I can read out the question for you. Papua New Guinea already has 2 handbooks to record maternal and child health. Since when these records have been used? Has it been implemented nationally in public health facility? Please, Ms. Mary.
Yes, sure. Yes, it's all in all public health facilities. These are the 2 recommended books that they have to use for the maternal and for the child separate.
Okay, so it has been implemented then. And then the second question also for you about the psychological preparation. I would to know some details on it. Would you like to?
Okay, when the pandemic hit our show last year, there were a lot of it. You know, COVID was a new thing to us, and it has affected a lot of healthcare workers where they were too scared and all this. So we had to get psychologists and psychiatric doctors. They were involved in teaching and going through us how we will handle the case and how will we get our minds prepared to get COVID-19 and to work with it. That's why we had to have a psychological preparation to accept that COVID-19. Yeah.
I see. Okay. Okay, thank you so much for your explanation. I think those two questions is for you, and the rest is for Mr. Jules. I don't know whether Mr. Jules is already joined with us. If he's not here because of the connection problem, then maybe we can try Mr. Jules directly. Miss Mary and also Dr. Alompon, I would like to kindly say my appreciation and thank you so much for this session. So I think we can adjourn this session. I will come back to the committee. Thank you so much for joining this session.
Thank you.
Congratulations for your
Thank
presentation.
you.
See you.
Thank you. Thank you, Doctor.
Thank you very much. Thank you very much, Dr. Sriwayuni, for moderating the panel. And also thank you very much for representative from Laos, Madagascar, and Papua New Guinea for your country presentation. And now, ladies and gentlemen, we will have a break for 50 minutes. So we will come back again after 50 minutes. So we will have a break right now and see you again in 50 minutes. Thank you very much.
Thank you.
Sini di depan ini pertama bagian dulu. Boleh saja ibu kadar bisa catat nama. Juga dipantau sama kadar bisa ya KIP ke ibu hamilnya.
Oh, berarti kita masukkan ke sini kalau
Tugasnya Nah, ini dari kata lainnya dari sini kita masuk ke bagian bayi. Saya tahu ini termasuk kategori normal atau harus apa namanya ada masalah apa tidak? Kalau solusi lain nanti juga
Pelayanan kesehatan bagi ibu dan anak pada masa pandemi ini lebih dititik beratkan pada pemberdayaan kader kesehatan dan ibu sasaran. Untuk meningkatkan pengetahuan kader tentang kesehatan ibu dan anak, Dinas Kesehatan Kabupaten Sumbawa Barat melaksanakan UKIA bagi kader-kader posyandu. Kegiatan ini dilaksanakan dengan tetap memperhatikan protokol kesehatan. Bidan Desa menjelaskan tentang informasi-informasi penting yang harus dipahami oleh kader terkait kesehatan ibu, bayi, dan balita. Buku KIA merupakan salah satu media KIE yang paling baik yang dapat digunakan dan dimanfaatkan oleh semua elemen.
Ambil gelasnya.
ambil gelasnya.
Ambil gelas. Jadi dikasih.
kunjungan pada sasaran balita, dilakukan juga kunjungan rumah dan pemantauan tumbuh kembang pada sasaran bayi. Hal ini sangat membantu memberi edukasi dalam pemanfaatan pemantauan perkembangan yang ada di dalam buku KIA kepada keluarga. Dalam kunjungan ini, tenaga kesehatan bersama kader lebih banyak melakukan pemberdayaan dengan mengajak ibu balita memahami isi buku KIA dan menerapkan dalam pengasuhan balitanya.
Kasih lurus kaki bukan, kasih lurus. Lurus sampai lurus kakinya. Ada 9. Saya sudah ya. Oh, saya. Sampai ASI so sampai di sini. Kasih yang dia apa selain ASI. Ya, mantap sampai karena itu teman biasa.
Pelayanan kesehatan pada ibu hamil dilaksanakan melalui temu janji dengan bidan desa. Sebelumnya, kader kesehatan melakukan kunjungan rumah dengan memberikan edukasi tentang tablet tambah darah kepada ibu hamil, sekaligus menginformasikan terkait temu janji pelaksanaan pemeriksaan kehamilannya pada bidan desa di wilayah kerja masing-masing. Selain kunjungan kader, bidan desa masing-masing wilayah juga sudah membuat grup WhatsApp komunitas ibu hamil, di mana wadah tersebut digunakan dan dimanfaatkan sebagai tempat berbagi informasi tentang kehamilan dan informasi tentang temu janji antara bidan desa dan ibu hamil.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD Subtask Force was formed under Coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD Subtask Force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated health care centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Layanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. Sidera atau stimulasi deteksi dini ramah anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD holistik integratif dan posyandu dengan bina keluarga balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua, di sini orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya. Kegiatan Sidera memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya. Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke poli DDTK di puskesmas. Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, Sidera memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempe menciptakan program inovasi Sidera, inovasi dini ramah anak. Tujuan inovasi Sidera adalah meningkatkan kualitas pelayanan kesehatan balita dan anak sekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation No. 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD Subtask Force was formed under Coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD Subtask Force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak sekolah kini memasuki era tatanan baru COVID-19. SIDERA atau Stimulasi Deteksi Dini Ramah Anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD holistik integratif dan posyandu dengan Bina Keluarga Balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua, di sini orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan SIDERA memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke Poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, SIDERA memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempe menciptakan program inovasi SIDERA, stimulasi deteksi dini ramah anak. Tujuan inovasi SIDERA adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD sub-task force was formed under Coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD Subtask Force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. Sidera atau stimulasi deteksi dini ramah anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD holistik integratif dan posyandu dengan bina keluarga balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan DDTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua, di sini orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya. Kegiatan Sidera memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Welcome back again to the second day of the knowledge sharing program of the maternal and child health. So in this session, we will have the country presentation again from Tajikistan and also from Indonesia. So please prepare for the Tajikistan representative and also for Indonesia representative. So in this session, will be moderated by Dr. Upik Rukubini from Ministry of Health. So without further ado, the time is yours, Dr. Upik.
Okay. Thank you, Ibu Master of Ceremony. Good afternoon, ladies and gentlemen. The honorable country representative of the audience who are present in this meeting. First of all, I would like thank you for giving me the opportunity to participate in this very honorable meeting. Ladies and gentlemen, my name is Upi Rukmini. I represent of the Director of Primary Healthcare. We lead our discussion in this session. Well, now we will enter the final session of the country report about implementation maternal and child health handbook during pandemic era from Tajikistan and Indonesia. Ladies and gentlemen, our guest speaker in this session are Ms. Iskakova Shirin from Tajikistan, and Dr. Lalu Hamzi Fikri from Indonesia. So there are only 2 speakers will be attending for today. Welcome to our forum for today, Ms. Iskakova and Dr. Lalu. For this session, each of you have 10 minutes for presentation, and then we will come to question and answer session. Well, for the first presenter, I would like to invite Ms. Iskakova Shirin from Tajikistan. Please, Ms. Shirin, to present your country report. Time is yours.
Good afternoon. Dear colleague, I am presenting the Tajikistan.
Yes, please, Ms. Iskakova. You may continue your presentation. Udah mulai.
Next slide, please. I'm sorry. The first slide shows handbook looks like in our country. I'm sorry, the connection is not so good. First slide shows the how handbook looks like in our country. Please, next slide. Tajikistan. The Tajikistan is located in Central Asia. The population of Tajikistan as of January 1, 2021 was 9,504,000 people. In terms of population growth rate over 30 years, Tajikistan took first place among the Republic of the former USSR. The country is rich of water and green mountains. About 93% of the country consists of mountains. Next slide, please. Maternal and child health status in CDGs. In the Republic of Tajikistan, the maternal mortality rate in 2018 was 21.9 per 100,000 live births.
Next slide.
Next slide. No. Task and the status of their implementation. Revised of MCH Handbook by Ministry of Health and Social Protection of Population, and the process of revision, the group is working. Approval of expansion from Minister of Republic Health after evaluation, implementation of the guidelines in 3 now districts. To introduce the implementation of MCH Handbook by training, education to medical workers for all of districts and regions of Tajikistan. 631 medical workers were trained in new pilot districts. Next slide, please. sharing experience of empowering community through utilization MCH handbook or its equivalents in pandemic era were not carried out. Community capacity building was carried out exclusively within the framework of the prevention of COVID-19 by washing hands. Next slide.
I'm sorry, Ms. Shirin.
Next slide. Next slide, please. Since the onset of the COVID-19 pandemic, primary healthcare workers have been making daily home entire assigned population in order to identify the assigned population in order forms of COVID-19 at home and follow up. Next slide, please. Sharing experience of the participants in conducting monitoring and evaluation of the MCH handbook or its equivalents implementation were not carried out. Unfortunately, during the pandemic, no particular attention was paid to monitoring the implementation of the guide. And today, the main forces of the system are aimed at high immunization coverage of COVID-19. However, during the pandemic, antenatal care for pregnant women, immunization of children, and other services for maternal and child health were provided. Next slide, please. What do your country want to learn from other countries in order to meet your objective of the KSP? We would like to know what difficulties other countries have encountered in expanding the implementation of MCH handbook and how they have overcome these difficulties or these problems. Next slide. Next slide. Thank you very much. Thank you for your attention. And question? Any question?
Okay. Okay, thank you very much. You finish your presentation, Ms. Shirin? Okay, thank you very much. Your presentation lasts from 10 minutes. Well, you have 3 minutes again for presentation, but you have finished your presentation, Ms. Shirin. Okay, question for Ms. Shirin. You can read it in chat room. Well, ladies and gentlemen, the next and the last presentation will be given by Dr. Lalu Hamzi Fikri from Indonesia. Mr. Lalu Hamzi Fikri, his current position is head of West Nusa Tenggara Provincial Health Office. Lalu is from our country, and for this, please welcome Dr. Lalu Hamzi Fikri for present your presentation. Time is yours, Dr. Lalu.
Thank you, Mr. Upi, Mrs. Upi, for time. Hello, everybody. Before we begin, Mrs. Upi introduced myself. My name is Dr. Fikri. I'm a head of health department in West Nusa Tenggara Province. Today, I'm going to be talking about the implementation of maternal and child health handbook on the national health system in West Nusa Tenggara Province. Next slide, please. Nusa Tenggara Barat Province. First, I'll begin by geographic condition. province of one of province in Indonesia, near which Bali, and the population 5.3 million, and an area 20,153 square kilometers. And we have the largest islands in west is Lombok Island, and in the east Sumbawa Islands. We have 10 regency. Next slide, please. I want to show you maternal mortality in the last 5 years. Maternal mortality case in West Nusa Tenggara province fluctuated from 2015 until 2020. In general, there are still many maternal and newborn deaths caused by various factors from upstream and downstream, including access and quality of health facilities is not optimal, early detection of prevention of pregnancy complication is not optimal, response time in emergency condition maybe it's contribute, and regulation are still not supportive. However, currently in a shift, the place of maternal and newborn death, there are about 77% of maternal deaths and 68% of neonatal deaths occur in hospital. So the role of hospital in effort to reduce maternal and newborn mortality is very large. The readiness of facilities in infrastructure, competence of health worker, and good management support will greatly affect the quality of maternal and newborn health services in hospital. Next slide, please. This is a neonatal mortality in 5 years. Next slide. The neonatal in the last 5 years, like maternal mortality, where newborn deaths are caused by various factors. As I have said in the slide before. Next slide, please. This is post-neonatal mortality in the last 5 years. Neonatal mortality in 2020, the highest neonatal mortality was in East Lombok Regency with 78 deaths, and lowest than 2 districts, namely West Sumbawa and Dompu district with 2 neonatal deaths. Next slide, please. Under 5 mortality in the last 5 years has decreased from 75 cases of under 5 mortality in 26 to 46 cases of under 5 mortality in 2020. How about the toddler mortality in the last 5 years has decreased from 75 cases of under 5 mortality in 2016 to 48 cases of under mortality in 2020. Next slide. This is regulation. One of the efforts to accelerate the reduction of maternal, infant, and under 5 mortality is issues regulation. The local government is tasked with facilitating the implementation of health services to improve the health status of mothers, infants, and children under 5. Next slide, please. In this slide, I want to explain the current implementation of maternal and child health handbook on the national services system in West Nusa Tenggara province. Services provided to pregnant women and toddlers are still meeting the basic standard. During the pandemic, the pregnant women and toddler who come to healthy our facility need to follow the health protocols and get COVID-19 screening procedure. Of course, in health facility, teleconsulting using WhatsApp media is appropriate for the mom and toddler during this pandemic COVID-19 in order to reduce the risk of getting infected by minimize contact. This is also maintain access into health care during the pandemic by providing online observation using MCH Handbook as a tools. Health protocol, of course, applied at the health care facilities included the use of masks and the use of a chamber and then regular facilities disinfection. Next slide, please. How about the SDI-TK screening? Stimulation detection, early intervention, growth and development. The participant progress of last year action plan in KSP 2020 or before. So the utilization of family-based newborn monitoring format put together with MCH Handbook to ensure newborn remain in normal condition until 30 days of their age. The implementation of SDIDTK screening in infant and toddlers at the community level in Posyandu and family level to see the infant and toddlers growth and development confirmed to their age using MCH Handbook. Periodically, strengthening facilitative supportive of family health during the pandemic COVID-19 to ensure service and infrastructure facilities and healthcare facilities are meeting the standard. Next slide, please. This is a picture when we association in the use of 2020 refish MCH Handbook to 10 residencies. So the purpose delivering information to health workers about the revision of the MCH, namely change in maternal and child health services standard. The participant, of course, from coordinator, midwife, and puskesmas doctor, and we have 173 puskesmas. The professional organization. Maternal health services in the form of antenatal care visit changed from 4 visits to 6 times, whereas twice antenatal care service will be screened and examined by doctor, namely in first and third trimester and other edition to the 2020 MCH book revision book. I changed in the postpartum visit from 3 times to 4 visits, and I changed in the child health service in the revision of MCH book are in the form of more comprehensive child service and information or children health until children are 6 years old. Next slide, please. This is monitoring and evaluation of the availability of MCH book in the health facility by looking at the services at the puskesmas and family posyandu in all the purpose to ensure that maternal and child health services and carry out according to standards in health facility and posyandu, and ensure that the MCH Handbook is a medium communication between health worker and the target family, and between health worker and other health worker, and use the MCH Handbook as a media for communication material for pregnant women and their families. We have a family posyandu implemented in the village as an integrated service, starting service for pregnant women, infant, toddlers, adolescent, productive age, and the elderly, as a place to do activities, screening, community empowerment, and providing comprehensive. Next slide, please. Improving the quality of maternal and newborn health services in hospital. So the purpose is looking for problem causing maternal and newborn mortality to the point of quality improvement method. Monitoring and evaluation carried out by the team to improve the quality of maternal and newborn health service at hospital. We do a collaboration. Next slide, please. Collaboration with UNICEF and public health expert. Okay. Thank you. Finally, we have a program for program Family Posyandu. It's to support this program. Thank you very much for presentation, and Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Mr. Ralu Hamzi Fikri, for your presentation. And thank you for Mr. Sirin for your presentation about implementation of maternal and child health handbook during pandemic in your country. Well, ladies and gentlemen, now we are come to the opinions, question and answer session. Please put your question in the chat room. Okay. Is Tajikistan delegate has still joining in this meeting, Miss Shirin?
We still hear you.
Okay, thank you. There is one question for you.
Chat
room from Timor-Leste. This question, I will read it. Does the home visit conducted within routine program or initiated during the COVID-19 pandemic? Is there any difficulties or challenge with the home visit activity considering the restriction of movement and other COVID-19 presenting issues? Please, Mr. Shirin, you can answer this question. Please, Ms. Shirin, or your
thank
team.
you for your questions. Usually home visit is the routine activity in Tajikistan. And when the pandemic, it will be
During pandemic, routine visit at home was very active and more active than before.
and conducted every day.
Every day.
We have so difficult in the early of pandemic when we have in the beginning we have not enough Individual
uniform.
uniform, mask and form.
At the beginning, we didn't have uniform for medical workers, for health workers, but gradually we got it. But visit at home, it was routine, and health workers very active. Were very active at the time.
Family nurses, family doctors. Rural health center, home, health home.
Well, thank you, Ms. Sirin, for your answer. For Timor-Leste, I hope you can hear well the answer from Tajikistan, because I think I cannot hear well what is the voice of this answer from Tajikistan. Maybe because of Wi-Fi in Tajikistan not well, I think. Is it true, Ms. Shirin? Okay.
Repeat kursus. Dan we understand that we repeat our question.
Okay, please you repeat. Or for Timor-Leste, is this clearly answer from Tajikistan?
Yeah. At beginning of the pandemic, our health workers were very active. Visit to home were routine. Every day, at time on time, our health workers visited the sick person or sick patient. But at beginning, it were difficult, a little bit difficult, because we didn't have the uniform for health workers. But gradually we got it, and routine. It was a routine in our country.
Home visits is a routine activity in our country. Every day, family medicine, family doctor have a home do a home visit. And during pandemic, this activity was more active.
Well, thank you, Ms. Shirin and team, for your answer. Finish? Okay, thank you. I think it's clear. Next question from Timor-Leste 2 for Indonesia. Please, Dr. Fikri, you can answer it from Timor-Leste. This question about okay, I think from Timor-Leste only opinion, yes. Can you respond opinion from Timor-Leste, Dr. Fikri? From Timor-Leste only opinion, I think. And
yeah. I think about the case of maternal death in 2020, because one of them due to COVID-19. We have a certain case. We have data in 2020, 122 case of maternal death, and 13 of them were mothers suffering from COVID-19. Maybe there's any question about the antenatal care. We have antenatal care for time services become 6 times. 2 times the service is carried out by doctor, and 4 times by midwife. How about the question about news tele consultation?
From Kenya.
Yeah. Not all pregnant women have cellular telephone, but it is very helpful in disseminating information. Cell phone usage around maybe about 15%. Thank you.
I'm sorry, Dr. Lalu. Any question from Kenya? There is question from Kenya. What is the essence of changing from 4 to 6? Has added any value? From Kenya, and then from Kenya again.
Yes, I have asked that question that maybe if it has added any value from 4 visits to 6 visits.
This, Dr. Lalu, can you respond? Question from Kenya.
From Kenya. Thank you. Question from Kenya. POCKI is monitoring the improvement of the quality of services in hospital, but services for the elderly are at the family posyandu. We have a family posyandu to screening case in the village and referral to puskesmas. Thank you.
Okay. Well, thank you, Mr. Fikri and Ms. Shirin, for your answer and for your opinion about question from the audience. I think all of question was answered by presenter, and finally, we finish this session discussion about implementation of maternal and child health from Tajikistan and Indonesia.
Yes.
Wait a moment. Sorry.
Hello.
Oh, okay. Oh, I'm sorry. Please.
Yeah, because I would like to ask. I would like to ask the question to the Indonesian participant because he mentioned about the maternal death due to the COVID-19 infection. Because you mentioned that the COVID-19, the maternal mortality ratio is increased from 2019 to 2020 is increased. But he mentioned about the maybe die due to the COVID-19 because we also have the 4 case maternal deaths in Laos because of. Are you sure that they are the main cause of death is the COVID infection or the obstetric complication? Like us, we have the eclampsia plus COVID-19, but the mother die is not due to the COVID-19, due to eclampsia. But coincidentally, they have the COVID positive test, something like that. Because we should, based on the maternal death review, to identify the main cause of death, underlying cause, and under the antecedent cause, based on the principle of the maternal death review. Are you sure that this is died due to the COVID-19 or due to the obstetric complication? This is my.
Okay.
Yeah.
Thank you, Mr.
Thank you.
Dr. Lalu.
Yeah. Thank you for your question and opinion. We have about the services in the pandemic. Services provided during the pandemic experience, slight change, such as screening carried out at the health centers and monitoring carried out independently by families using MCH Handbook. I think maybe if you want another answer, I hope this satisfied the answer. Thank you.
Thank you, Dr. Fikri, for your answer. Is it clear for Lau? Well, any question again? Well, ladies and gentlemen, we have finished for this session, I think, and we would like to say thank you to all our presenter, Ms. Iskako Fashirin and Mr. Lalu Hamzi Fikri from Tajikistan and Indonesia. And thank you for all of the audience for your active participating. Hopefully the presentation will give the benefit for us. Finally, give the house for the speakers and all of us. Thank you for your attention and bye. See you again. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Upi, for moderator the panel. And also I would like to thank you for the representative from Tajikistan and also from Indonesia, Dr. Hamdi Fikri, for your presentation. Ladies and gentlemen, we have another special session after this, but before we enter the special session, I would like to remind to all of you, to the ladies and gentlemen, to link to if you have downloading the presentation, you can check in the Zoom link. And also I would like to remind you to fill in the evaluation form and also the attendance form after this. So all the presentation can be downloaded through the link that in the chat box, so please do so. After this, we will have a special session. We'll have a session about the effort to control COVID-19 in mothers and children that will be delivered by Dr. Erna Muati, Director of Family Health Planning, Ministry of Health, and will be moderated by Ibu Dian Savitri from Ministry of Health. The time is yours, Ibu Dian.
Okay, thank you, host. Good morning, good afternoon, distinguished participant. I hope I'm audible enough. Okay, so my name is Dr. Dian Savitri. I'm Deputy Manager of Immunization Program in Ministry of Health Indonesia. I will be your moderator in this special session. With presentation from the Director of Family Health, Ministry of Health Indonesia, Dr. Erna Mulyati, MSc, CMFM. Dr. Erna will be presenting the COVID-19 response on pregnant women and children. Without further ado, Dr. Erna, I will give you the floor.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. First of all, let's praise Allah, the most gracious, most merciful, for allowing us to gather here at the second day of knowledge sharing program on maternal and child health handbook 2020. I am pleased to welcome all participants from Kenya, Tajikistan, Cambodia, Timor-Leste, Madagascar, Thailand, Papua New Guinea, Laos, PDR, and Indonesia. I would also like to express my appreciation to the committee for their hard work to organize this meeting, and JICA for your continued support concerning the development, implementation, and the improvement of MCH Handbook in Indonesia. Ladies and gentlemen, in this session, I'm very pleased to share you the MCH services and COVID-19 response in Indonesia. Distinguished delegates, currently the cumulative number of confirmed cases in Indonesia goes beyond 4 million cases, and sadly, around 3.4% of these cases were died. The COVID-19 infections occurred nationwide, as shown in the map. The highest number of cases detected in the big cities. The infection affected all age groups, from infant to elderly, as described by the bar chart, which illustrates the prevalence of COVID-19 by age group. The highest prevalence is among the productive age group, while the highest percentage of death is among the elderly. Due to the unfavorable outcome, pregnant women could be categorized as a vulnerable group. 10% of the confirmed cases are pregnant women, and 0.2 among that are also pregnant women. Meanwhile, 2.9% of the confirmed cases are under 5 children. The under 5 children also contribute to 0.5 of that. As we are aware, the COVID-19 pandemic, which has been going for almost 2 years, has affected many of life aspects. In terms of health services, the pandemic has reduced the opportunity of population to access essential services. During the early months of pandemic, the Ministry of Health has conducted during the early months of pandemic. The Ministry of Health has conducted a rapid survey which told us that the pandemic condition which resulted in the activity restriction told us that the pandemic condition which restriction reduced the services delivery through the integrated health post as one of the important essential services point in the community. In that time period, almost half of integrated health posts were closed. Furthermore, patient visit to the primary health center also decreased. If we compare the coverage of MCH services between pre and pandemic period, as illustrated in the bar chart, we could see that their coverage decreased for the antenatal care from 19.2% to 86%. Health facility delivery which decreased for 10%. Complete basic immunization from 19.3% to 18.3%. While the coverage of neonatal visit is considerable, stable, and under 5 growth and development monitoring showed a positive trend. Perhaps it caused by our massive export to increase the utilization of MCH Handbook as tool for family to do the self-monitoring for their toddlers. To overcome the pandemic situation, the government of Indonesia has established many policies in order to limit the disease spreading, the disadvantage outcome of infection, well control the pandemic impact in the economic and social aspect. Since the first case detected in Indonesia, the government has been implementing the community and active restriction, which regulate working activities such as regulation for workplace capacity and work from home policy, both for essential and non-essential sector. Economic activities which manage business hours of economic sector. Distance learning in the education sector, travel and transportation activities, and also since the rise of COVID-19 infection in Indonesia has associated with the holiday event. The government also controls some social activities, including regulation activities. Even though established since the early state of pandemic, the activity restriction applies considering the pandemic situation. During the second wave of pandemic, the restrictions were strictly enforced, and gladly, currently, the number of cases has reduced significantly, and some of the restrictions are more loosely. Indonesia has been delivering COVID-19 vaccination since the beginning of this year, which divided into 4 phases of the population priority, which are health workers, public services, vulnerable community, and general public. Nowadays, the vaccination are delivered into all groups. Considering the higher number of COVID-19 infection among young people and the outcome of infection for pregnant women, since August this year, both groups included in the vulnerable community. Ladies and gentlemen, during the establishment of the activity restriction, the government also controls transportation and mobility. For overseas travelers, country entrance are limited in only certain ports, and travel, both citizens and foreigners, are required to be quarantined for 8 days and now 5 days. For domestic travelers, those who are population target must show their COVID-19 vaccination certificate at least for the first dose. Travel within cities or from and to the island of Java and Bali, or from and to the assessment level 3 and 4 areas require 48 hours of negative PCR result for travel by plane, and then 24 hours of negative antigen test result for land and water mode of public transportation. Travel outside of island of Java and Bali or from and the assessment level 1 and 2 areas require 48 hours of negative PCR result or 24 hours of negative antigen result for travel by plane and land and water mode of the public transportation. As stated in the previous slide, the regulation of activity restriction is adaptable to the fluctuation of pandemic situation. The evaluation is conducted in the district level with the consideration of community transmission, which include the indicator of confirmed case, inpatient case, and death. Response capacity, which consider the testing, tracing, and treatment capacity, and vaccination coverage. Those indicators are being assessed weekly, which generate the pandemic situation level by district, which regulated by the instruction of Minister of Home Affairs. Based on the leveling from the considerable good condition of level 1 to the worst condition of level 4, the instruction of Ministry of Home Affairs regulated the different level of restriction in the community activities, which manage learning activities in school, the activities on the non-essential, essential, industrial, and the infrastructure construction, trading activities in traditional markets and shopping centers, restaurant opening then in capacity or worship place and religious activity, and the community activities in public area, socio-cultural, and sport. currently from 514 districts in Indonesia, none of them in the level 4 of pandemic situation. Thus, the school can be reopened with strict health protocols. The maximum capacity of workplace is increased up to 50% for non-essential sector and 100 for essential sector and industry. Mall and shopping centers are allowed to be visited by all age group, but all visitors has been screened by their vaccination and infection status in the entrance using the mobile phone application. Then in the service in the restaurant is allowed by the maximum of 50% capacity up to 9 o'clock in the evening. The maximum capacity of workplace in increase up to 50%, and activities in the public area are allowed by 50% capacity. And for the sport event, we even have successfully arranged the national sport event with the strict health protocols. Ladies and gentlemen, as part of effort in pandemic control, Indonesia has been administering the COVID-19 vaccination to reach the target of 208 million population, which consists of health workers, elderly, public service, vulnerable community, and general public. In this time being, 44% of targeted population has received the first dose of vaccination, while 33% has received the full dose vaccination. The achievements are resulted by the cross-sectoral collaboration in the vaccination. In Indonesia, the vaccination are also supported by police and army, non-government organization, civil society, and even private sector. As recommended by the Indonesia Technical Advisory Group on Immunization and Indonesia Society of Obstetric and Gynecology, for the pregnant woman can get the mRNA vaccine such as Pfizer and Moderna, or inactivated platform such as Sinovac. The first dose can be administered in the second 3 semesters, and the shot of prioritized for the high risk group with a high risk pregnancy for the more than 35 years old with the BMI more than 40, diabetes, and also hypertension. High risk of COVID-19 exposure. For the low risk group, the vaccination based on the mother decision after counseling. COVID-19 vaccination for the pregnant woman and above 12 years old. As recommended by the Indonesia Technical Advisory Group and Immunization and Indonesia Society of Obstetric and Gynecology, the pregnant woman can get the MR vaccination. While for the 12 and 70 years old, they get vaccination by vaccine Pfizer and Sinovac. Ladies and gentlemen, during the pandemic, the infection prevention measures should be applied into all aspects. For the maternal and child health, the implementation of the vaccination, the policy to prevent and controlling the COVID-19, including to protect mother and child as follows. 1. The strengthening the community restriction, work from home policy prioritized for pregnant women, nursing mother, families with early childhood. online preschool activities, supervise mask compliance, and also antigen test for long-distance modes of transportation. The second, provision of essential health services, implementation mother and child services as health facilities. Posyandu through appointment and COVID-19 risk screening, immunization with mobile health center, and the capacity building for the preschool teachers cadre to health. For the protection, COVID-19 vaccination for pregnant women, breastfeeding mother, and children aged 12 and 17 years. Provision of mother-child services in COVID-19 referral hospital. The MCH services delivery and COVID-19 response could not be implemented without the collaboration of the government, civil society, and the community. For the adaptation of health facility. In the pandemic situation, maternal and child health services must continue to run to fulfill the right to health of mother and children. The effort to reduce maternal, infant, and under 5 mortality must be carried out optimally even in the pandemic situation. Based on the need assessment, we are modifying maternal and child health services to maintain continuity of the health services, to reduce the risk of COVID-19 transmission, and to protect health workers. We learned that it is important to strengthen the use of technology or digitalization for tele-registration, to implement triage to separate the patient from risk of COVID-19, to use the appropriate personal protection equipment, and to modify essential MCH services. Ladies and gentlemen, based on the needs of our adaptation of health services, we modify most of MCH services. Regarding the maternal health care adaptation, covers services for antenatal care, childbirth, postnatal care, family planning, and contraception, and newborn care. For the antenatal care consists of tele-appointment and registration, include COVID-19 risk screening. Screening for the risk factor and USG performed by doctors in the first trimester and third trimester. The USG postponement. For the pregnant mother suspected or confirmed for the COVID-19 infection postponed. Pregnant mothers and family are expected to learn from the MCH handbook and must be aware of the danger sign. Counseling for the pregnant mothers suspect or the confirmed COVID-19. The second, childbirth, consists of self-isolation for at least 14 days before the due date to reduce the risk of infection. Plan referral. The choice of delivery place should consider pregnancy risk factor and COVID-19 status. The postnatal care for suspect confirmed case is postponed. Mother and family are expected to learn from the MCH handbook and should be aware of the danger sign. First postnatal care visit is performed in the health facilities, while the second, third, and fourth postnatal care depend on the COVID-19 situation in this area. For the family planning and contraception, using the tele-appointment, infection prevention control, and preferably long-term contraception. For the newborn, early breastfeeding initiation, and coming independent on mother COVID-19 status and condition. For the under 5 children, healthcare adaptation are implemented in the community level, educational and social institutions, and health facilities. In the community level, activities consist of outreach activity depend on the COVID-19 local situation. Prioritizing COVID-19 transmission prevention, family conduct growth and development monitoring using the MCH Handbook, immunization supplementation monitoring for the high-risk children could be assessed by appointment in the health facility. While in the educational and social institution, the adaptation implemented by home-based learning with healthy schedule, new life adaptation education using masks, hand washing, physical distancing, screen time limitation, teleparenting class, school infrastructure readiness. In the health facility, by prioritizing COVID-19 transmission prevention, suitable PPE, triage, service area arrangement, and MCH essential services and teleappointment. Ladies and gentlemen, in the pandemic situation, maternal and child health services must continue to run to fulfill the right of health of mother and children. The effort to reduce maternal, infant, and under 5 mortality must be carried out optimally even in the pandemic situation. In the community level during the pandemic period, the community-based health post implementation depend on the COVID-19 situation and the local government policy. When the post close, health services are postponed and families are encouraged to do the self-monitoring efforts to the instrument on the MCH Handbook and the health services delivery in the primary health center by appointment or home visit when needed. While whenever the post open for services, all health services are adapted to prioritize the disease spreading. Families are still encouraged to do the self-monitoring for their children development, and to minimize the waiting time, the health post services can be divided by age group. In pandemic era, many unfortunate situations may affect our children's life. To prevent the loss of learning, the government regulated the adaptation in education sector. According to the joint decree for ministers, schools are allowed to open for face-to-face learning by meeting the protocol requirement. However, parents could decide whether they could choose to permit their children to face-to-face learning or distance learning. And the central government holds the authority to establish the school closing policy as part of the pandemic control whenever necessary. This is the guideline of information, education, and material developed in the early pandemic in the year 2002 and have been socialized in the health workers. Next slide, please. Next slide. The guideline of management COVID-19 under the ministry degree have determined special chapter for mother and child health in terms of clinical science, severity, and treatment. And the last slide, besides the adaptation in health services, the government has also assigned COVID-19 referral hospital across the nation to provide COVID-19 treatment for the communities. Those hospitals not only owned by the government, but also private sector. Through the assignment, we hope that the medium or severe cases can be treated well to reduce the case fatality. The participant, that's all the illustration of MCH services and COVID-19 response in Indonesia. We realize that all of us still learning to implement the best measure for the pandemic response. I hope This presentation could be as a lesson learned to improve the health services during the pandemic as our effort to prioritize the delivery of essential health services with the infection prevention measurement and to control the COVID-19 pandemic. Thank you very much.
Okay, thank you, Dr.
Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Erna, for the presentation. So from the presentation, we know that in Indonesia, most primary essential health services have been affected by the pandemic, including the mother and children health care. So some policies have placed to address the situation, such as mobility restriction, testing, tracing, treatment, and COVID-19 vaccination. As for the affected essential health services, the mechanism has been adjusted and modified with restriction policies such as teleappointment and online registration prior accessing the health services. So, okay, we don't have a question and answer session for this session. So let's give a round of applause for our presenter. Okay, and I return the floor to the host. Thank you for your time.
Thank you very much. Thank you very much, Ibu Dian Sawitri, for moderating, and also thank you very much for Dr. Erna Mulyati, for Director of Health, for your comprehensive presentation about the effort in Indonesia to control COVID-19 in mothers and children. Thank you very much. Dear distinguished participants, we will move on to the next session. So we will have a summary of the day 1 session, and this summary will be delivered by Dr. Nida Rohmawati, Coordinator Maternal and Neonatal Health. So without further ado, before that, I think I want to remind you again. So for those who haven't filled in the attendance form, I will remind you to do so right now. And also later, I hope you also fill in about the evaluation form, because it is mandatory for you, the participants, to fill in the evaluation form, because we will, for those who haven't, this is as a base for us to the certificate form. And also, if we are already ready, we will move on to the next session. So the next session will be delivered by Dr. Nida Rohmawati, Coordinator Maternal and Neonatal Health, for give the summary of the day 2 session. Thank you very much. Dr. Nida, the time is yours.
Distinguished participants, ladies and gentlemen, good morning and good afternoon. Allow me to present the summary of the second day session. Today, we got many sessions from 2 speakers and 5 country presentations. From the first presentation by Ms. Keiko Osaki about the implementation of MCH Handbook in the ward and continuum of care, we have learned about what WHO guidelines gave directions about home-based record. The use of home-based records as a complement to facility-based records is recommended for the care of pregnant women, mothers, newborns, and children. And there was insufficient evidence available to determine if any specific type, format, or design of home-based records is more effective. And also, she talked about the steps to implement home-based record, from design and content, training, sustainability, planning, education, and include the potential of harm. And the most important thing is how to make MCH Handbook as a tool of continuum of care. We learned it from the Japan experience. Well, in the second session, we have learned from country presentation by Laos PDR, Madagascar, Papua New Guinea, Tajikistan, and also Indonesia. from the second presentation, there are several things that we can highlight it. In terms of community empowerment, we learned that Madagascar and also Papua New Guinea have two kinds of MCH handbook, one for mother and one for newborn to under 5 years old. Law PDR strengthened collaboration with mass organization and head of village to educate women and train the health worker for work with community in terms of the health promotion. And during COVID-19 pandemic, Madagascar provide mobile clinic, a learning platform, and also conducted the webinar. For capacity building, Law PDR had adaptation the WHO guidelines about the MCH services in the pandemic COVID. Papua New Guinea implemented psychological preparation on the pandemic. Tajikistan did the community capacity building was carried out exclusively within the framework of the prevention of COVID-19. And Indonesia developed teleconsultation using WhatsApp and or other media apps in offer for the moms and toddlers during this pandemic COVID-19 in order to reduce the risk getting infected by minimizing contact. While for monitoring and evaluation, Law PDR did clinical audit and chart review for ANC record, and Papua New Guinea set up a national control center which is run by Pandemic Response Task Force Committee. And there was a special sessions. The Director of Family Health of MOH of Indonesia shared us about effort to control COVID-19 in mothers and children by making a regulation of activity restriction, dissemination, the modified of MCH services guidelines during the pandemic. COVID-19 vaccination include for pregnant women, and also role of the MCH handbook for self-help monitoring in the community, and the last, utilization of technology and information system. Finally, I would like to express my appreciation for all presenters. We learned a lot about the role of MCH handbook and how to recovery from the MCH services, how to recovery the MCH services from COVID-19 pandemic. I would like to express my congratulations and thank you for all participation. And we will continue to the group work. Thank you.
Thank you very much, Dr. Nida, for your comprehensive recap for the summary of the day 2. So, ladies and gentlemen, we will move on to the next session. In this session, we have an evaluation session, and Mr. Egi will assist you again to help you to how to fill in the attendance form. Mas Egi, the time is yours.
Thank you, Mrs. G. Thank you very much, distinguished participants. Is it my honor to meet you again today on the second day of the CASP MCH 2021. Again, my session is going to assist you regarding evaluations. I believe that you already got the evaluation link through the chat box. If you have any difficulties or any questions regarding the evaluations, this is your chance, your opportunity to share your feedback. Please let me know if you have one. From the past today, I believe the discussion was very fruitful, despite many challenges such as the network, perhaps, and also due to the time management and everything. But I hope that you have a good and fruitful session today. Again, if you have any difficulties regarding the evaluations, please let me know. This is the chance, the opportunity for you to share your feedback or your response regarding the evaluation form. Again, to remind you that please keep in mind that the one who will obtain the certificate from this training is the one who completed the evaluation form. So make sure that you finalize and complete the evaluation form. And again, if you have any difficulties, please let me know. From our data, of 27 participants, only 12 participants already completed the evaluation form. Again, if you have any difficulties accessing the evaluation form, let me know. You can just write down in the chat box, or you can ask me directly. We have around 10 minutes to solve or to discuss about the evaluation form. Any difficulties, any issue regarding the evaluation form, or perhaps you have a bit of challenge to understand the questions? I'm here to assist you, to help you regarding the evaluation form. The evaluation is very valuable for us, so we can know your point of view regarding the training, so we can improve for the future program. Again, we design the evaluation as simple as possible, and also we develop the questions to be much easier understand by you. I believe my assumption that there will be no difficulties, but if you have one, please let me know. We have shared the link to the evaluation form on the chat box. Again, please keep in mind that you have to complete the evaluation form before the third day or the final day of our training program, which is tomorrow. Anyone would like to give something regarding the evaluation form? We have 13 participants who already completed the evaluation form. If I may give a bit of information, so we have response from Laos, PDR, Kenya, Cambodia, Thailand, Madagascar. We still haven't seen any response from Tajikistan, Papua New Guinea. So please, participants from these countries, do you have any difficulties regarding the evaluation form? That is my sessions, or do you have any questions? Yeah, we will have another session tomorrow, but I wish that we hope that you can complete the evaluation form before the end of the program tomorrow. So I guess if you don't have any questions, I assume that you already have full understanding regarding the evaluation form. Okay, I think I can end my session today, since there is no question or feedback from you. I will give it back to the Mrs. Yoshita. Thank you very much. That's it from me.
Thank you very much, Mr. Egi. Thank you very much. Ladies and gentlemen, again, I would like to remind you to all the participants who haven't filled in the attendance form as well as the evaluation form, please, I would like to kindly remind you to do so. And also, the copy of the presentation can be seen through the link that in the chat box. So I would like to remind also that tomorrow is become our last day for the session for the knowledge sharing programs. So the training, the knowledge sharing programs will be conducted again at 1 p.m. Jakarta time, and we will use the same Zoom link as today. So please make sure be there. So for the tomorrow session, we will have a group discussion again, and also we have a presentation of action plan, and also you from all the countries will get the feedback on the action plan. So after this, we will have a group discussion again like yesterday. So please, I would like to remind to ladies and gentlemen, distinguished participants, please do not leave the Zoom application first, because we will have a group discussion again. So you can sharpen your ideas there, and also you can give your input or something like that about the action plan for tomorrow and for the presentation. So please have be there for the group discussion after this. So after this, we will divide you into the breakout rooms. So please be there. For me, thank you very much, and see you in the group.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD sub-task force was formed under Coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD sub-task force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Child Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. SIDERA atau Stimulasi Deteksi Dini Ramah Anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD Holistik Integratif dan Posyandu dengan Bina Keluarga Balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua di sini, orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya. Kegiatan SIDERA memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP. dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Bila masih ditemukan penyimpangan, dilakukan rujukan ke poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, Sidera memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempeh menciptakan program inovasi sidera, stimulasi, deteksi dini, ramah anak. Tujuan inovasi sidera adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation No. 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD sub-task force was formed under Coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD sub-task force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. Sidera atau stimulasi deteksi dini ramah anak di Puskesmas Tempeh Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD holistik integratif dan posyandu dengan bina keluarga balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua di sini, orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua, termasuk masalah tumbuh kembang anak, vaksinasi, dan lain sebagainya.
Kegiatan Sidera memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke Poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, Sidera memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempeh menciptakan program inovasi Sidera, stimulasi, deteksi dini, ramah anak. Tujuan inovasi Sidera adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD sub-task force was formed under coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD sub-task force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. Sidera atau stimulasi deteksi dini ramah anak di Puskesmas Tempeh Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD holistik integratif dan posyandu dengan bina keluarga balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan DDTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua, di sini orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat, di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan Sidera memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, Sidera memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempeh menciptakan program inovasi Sidera, stimulasi deteksi dini ramah anak. Tujuan inovasi Sidera adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD sub-task force was formed under coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD sub-task force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. SIDERA atau Stimulasi Deteksi Dini Ramah Anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD Holistik Integratif dan Posyandu dengan Bina Keluarga Balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua di sini orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan SIDERA memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena sesuai dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke Poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, SIDERA memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempe menciptakan program inovasi SIDERA, stimulasi deteksi dini ramah anak. Tujuan inovasi SIDERA adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD sub-task force was formed under coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD sub-task force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, address of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. Sidera atau stimulasi deteksi dini ramah anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD holistik integratif dan posyandu dengan bina keluarga balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua di sini, orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan Sidera memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke Poli DDPK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, Sidera memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempe menciptakan program inovasi Sidera, stimulasi deteksi dini ramah anak. Tujuan inovasi Sidera adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD subtask force was formed under coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD subtask force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. SIDERA atau Stimulasi Deteksi Dini Ramah Anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD Holistik Integratif dan Posyandu dengan Bina Keluarga Balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua di sini, orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan SIDERA memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, SIDERA memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempe menciptakan program inovasi SIDERA, stimulasi deteksi dini ramah anak. Tujuan inovasi SIDERA adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD subtask force was formed under coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD subtask force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. SIDERA atau Stimulasi Deteksi Dini Ramah Anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD Holistik Integratif dan Posyandu dengan Bina Keluarga Balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua di sini, orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan SIDERA memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke Poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, Sidera memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan Puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini Puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DDTK, Puskesmas Tempeh menciptakan program inovasi sidera, stimulasi, deteksi dini, ramah anak. Tujuan inovasi sidera adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD sub-task force was formed under coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD sub-task force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in three fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. Sidera atau stimulasi deteksi dini ramah anak di Puskesmas Tempeh Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD holistik integratif dan posyandu dengan bina keluarga balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua di sini, orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan Sidera memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke Poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, Sidera memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDIDTK, Puskesmas Tempe menciptakan program inovasi Sidera, stimulasi deteksi dini ramah anak. Tujuan inovasi Sidera adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation No. 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD sub-task force was formed under coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD sub-task force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. Sidera atau stimulasi deteksi dini ramah anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD holistik integratif dan posyandu dengan bina keluarga balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan DDTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua, di sini orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat, di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan Sidera memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke Poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, Sidera memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempe menciptakan program inovasi Sidera, stimulasi deteksi dini ramah anak. Tujuan inovasi Sidera adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD sub-task force was formed under coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD sub-task force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated health care centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Layanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. SIDERA atau Stimulasi Deteksi Dini Ramah Anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD holistik integratif dan posyandu dengan bina keluarga balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua di sini, orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan SIDERA memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke Poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, SIDERA memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempe menciptakan program inovasi SIDERA, stimulasi deteksi dini ramah anak. Tujuan inovasi SIDERA adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD sub-task force was formed under Coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD sub-task force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city government to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. SIDERA atau Stimulasi Deteksi Dini Ramah Anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD Holistik Integratif dan Posyandu dengan Bina Keluarga Balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua, di sini orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan SIDERA memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke Poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, SIDERA memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempe menciptakan program inovasi SIDERA, stimulasi deteksi dini ramah anak. Tujuan inovasi SIDERA adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD Subtask Force was formed under Coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD Subtask Force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. SIDERA atau Stimulasi Deteksi Dini Ramah Anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD Holistik Integratif dan Posyandu dengan Bina Keluarga Balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua di sini, orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan SIDERA memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke Poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, SIDERA memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempe menciptakan program inovasi SIDERA, stimulasi deteksi dini ramah anak. Tujuan inovasi SIDERA adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah dalam deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas dalam akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights. as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD sub-task force was formed under coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD sub-task force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan kesehatan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. SIDERA atau Stimulasi Deteksi Dini Anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD holistik integratif dan posyandu dengan bina keluarga balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada buku KIA. Jadi dengan adanya peran orang tua di sini, orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan SIDERA memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi dengan benar, gizi seimbang dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak-anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak dengan menggunakan KPSP dan hasilnya akan direkap dan dilaporkan ke puskesmas. Jika ada penyimpangan, dilakukan intervensi dan stimulasi ulang. Apabila masih ditemukan penyimpangan, dilakukan rujukan ke poli DDTK di puskesmas.
Untuk meningkatkan efektivitas pelaporan screening KPSP dan juga mengurangi tatap muka, SIDERA memanfaatkan teknologi yang sederhana yaitu dengan Google Form. Dengan Google Form ini nanti para guru akan melaporkan hasil dan puskesmas akan menindaklanjuti dengan intervensi dan juga stimulasi. Ternyata dengan cara ini puskesmas bisa mempertahankan pelayanan DDTK pada balita dan anak prasekolah walaupun di era pandemi dan tatanan baru.
Untuk optimalisasi kegiatan SDI DTK, Puskesmas Tempe menciptakan program inovasi SIDERA, stimulasi ini tujuan inovasi Sidera adalah meningkatkan kualitas pelayanan kesehatan balita dan anak prasekolah, deteksi tumbuh kembang dan intervensi dini. Dengan adanya inovasi ini diharapkan dapat menjadi daya ungkit dalam pencapaian target SPM dan mendukung program prioritas akselerasi penurunan stunting.
Indonesian government is highly committed to the fulfillment of children's rights, as stated in the Child Protection Law, the Population Administration Law, the Health Law, the National Education System Law, etc. The Integrative Holistic Early Childhood Development Policy, which integrates relevant cross-sectors, has been outlined in Presidential Regulation Number 60 of 2013. Furthermore, to coordinate programs from the relevant ministries, an IHECD task force was formed under Coordinating Ministry of Human Development and Culture, with representatives from Ministry of Home Affairs and Ministry of National Development Planning or National Development Planning Agency. The IHECD Subtask Force coordinates Ministry of Health, Ministry of Education and Culture, Ministry of Women's Empowerment and Children Protection, Ministry of Social Affairs, etc., which works in 3 fields, namely early childhood education, health and nutrition, and early childhood care and protection. The IHECD policy is implemented in stages from the central, provincial, district or city governments to the village, involving public health centers, integrated healthcare centers, early childhood education care units, and toddler family development groups. The following is a video that illustrates collaboration across sectors of health, education, cadres of community organization for family empowerment and welfare at the integrated healthcare centers in monitoring early childhood health and development using the MCH Handbook as its main instrument.
Pelayanan balita dan anak prasekolah kini memasuki era tatanan baru COVID-19. Sidera atau stimulasi deteksi dini ramah anak di Puskesmas Tempe Kabupaten Lumajang merupakan salah satu upaya layanan terintegrasi dengan PAUD holistik integratif dan Posyandu dengan Bina Keluarga Balita.
Posyandu dengan 5 meja kita optimalkan dengan tetap memperhatikan protokol kesehatan di area pandemi seperti ini. Pemeriksaan di DTK di sini kita arahkan ke pemberdayaan orang tua. Jadi di sini orang tua kita ikutkan aktif untuk menjaga tumbuh kembang pada anak dengan screening pada IA. Jadi dengan adanya peran orang tua di sini, orang tua jika ada masalah pada anak dapat langsung melaporkan kepada bidan sehingga dapat dilakukan deteksi dini untuk stimulasi dan intervensi gizi.
Kolaborasi dengan program Bina Keluarga Balita memanfaatkan kantong wasiat. Di situ kita bisa memberikan edukasi kepada orang tua termasuk masalah tumbuh kembang anak, vaksinasi dan lain sebagainya.
Kegiatan Sidera memberikan edukasi dan promosi kesehatan mengenai pola bersih hidup sehat dan demo gosok gigi, cuci tangan dengan benar, gizi seimbang, dan pengenalan tanaman toga. Ini tentu saja sangat bermanfaat bagi PAUD HI karena selaras dengan kurikulum K13. Anak tidak hanya belajar dalam kelas, tapi belajar bermain langsung dan praktek langsung pada ahlinya.
Guru PAUD melakukan pemantauan deteksi dini tumbuh kembang anak